Hello and welcome to lecture number 2 for chapter 2 for hospital-based care systems. We are picking up on page 51 with coding and classification. Alright, so as we discussed in health records, we talked about ICD-10, International Classification of Diseases, and then we actually covered 10 CM and 10 PCS. 10 means it's the 10th revision, and CM means clinical modification. So the clinical modification of the International Classification of Diseases developed by the National Center for Health Statistics is the classification system used for coding the patient's condition, diagnosis, or reason for encounter for inpatients and outpatients. So we actually moved from ICD-9 CM to ICD-10-CM in October of 2015, and PCS was also updated from 9 to 10 in 2015 as well. And remember from health records that, like we just stated, your clinical modification, the ICD-10-CM, which is your diagnoses, is used for both inpatients and outpatients, but ICD-10 PCS is only used for inpatient coding. You're going to use CPT or the HCPCS codes for your hospital outpatient procedure coding. Alright, so dropping down to HCPCS, the Healthcare Common Procedural Coding System is the system required by CMS for coding services provided to Medicare patients. CMS adopted the American Medical Association's current procedural terminology, or CPT, as the coding system comprising the bulk of HCPCS. The CPT codes are designed by the CMS as level 1 codes, or designated. The codes that the CMS developed are known as HCPCS level 2, or national codes. They're alphanumeric codes consisting of a letter, A through V, and 4 numerical digits. Then we've got revenue codes. Revenue codes are reported on the UB04 to indicate the general nature of the services provided, such as pharmacy, room and board, or intensive care. And to file a valid claim, the revenue code must be appropriate to the HCPCS code listed with it. Therefore, to avoid rejection of claims, the appropriate revenue codes usually are included in the charge master file, along with the HCPCS code for the services being billed. Alright, we got different kind of coding edits to talk about as well. Our MACs, our Medicare Administrative Contractors, process hospital inpatient bills using the Medicare Code Editor, the MCE, and the hospital outpatient claims using the Outpatient Code Editor, the OCE. These code editors identify coding errors on hospital bills that can cause the claim to be rejected. The National Correct Coding Initiative, NCCI, or your CCI, edits also apply to the APC system. The purpose of the CCI edits is to prohibit unbundling of procedures, a practice that results in extensive payment to the provider when multiple codes are reported instead of a combination code. Alright, moving down to data and information flow. This is where we're going to talk about registration, our MPI, and then some documentation here. So most facilities, the patient's record is started at registration. There's information necessary to identify the patient. It's gathered and recorded, and this information is entered into an electronic database or your master patient index system. And it can also be printed out or manually recorded for immediate reference. Many electronic health records store a local version of the MPI on business continuity devices to ensure that the index is available during system downtimes. As various assessments, diagnostic procedures, and treatments are completed, the results are incorporated into the patient's record, along with the diagnostic impressions or conclusions and plans for future care. The patient's record must be readily available when a patient is seen in any hospital setting. And when a hospital uses an EHR, electronic health record, the patient's record can be accessed by diverse providers throughout the hospital as the patient arrives at various departments for different services. Hospital using a paper record or a hybrid record could achieve this goal by maintaining all components of the paper record together and delivering them to the hospital locations where the patient's being seen. All right, so dropping down on page 53 to the section labeled Electronic Health Records and Computer Systems. So, as within many areas of healthcare, the first computer applications in hospitals was related to billing. A lot of people think, all they ever care about is making money. Well, in the old days, I would say that's 100% true because, a lot of people don't think about this, but if you can't bill and be reimbursed for what you're doing, you can't keep your doors open. Supplies cost money. People cost money. I'm not going to go to work every day for very long anyway if I'm not getting paid for it. So the importance of maintaining clinical information electronically began to receive attention in the 1990s, and receiving impetus from the Institute of Medicine 1991 publication, The Computer-Based Patient Record, an Essential Technology for Healthcare. And although decades passed after this seminal work was released, the hospital lagged in the adoption of electronic health records. But we have talked about this a little bit. In 2009, Congress passed the American Recovery and Reinvestment Act, and it included a Medicare and Medicaid incentive program for healthcare providers who demonstrate the ability to meaningfully use an EHR. To meet the definition of meaningful use, providers must use a certified EHR product in such a way that an electronic exchange of information improves the quality of care provided to patients, including the capability of submitting clinical quality measures data. And although this program initially encouraged EHR adoption by providing incentive payments to hospitals and clinicians, the law included penalties for Medicare providers who did not meet meaningful use requirements after the conclusion of the program. And so we had 3 stages of meaningful use. Stage 1 meaningful use requirements focused on data capture and sharing, and were implemented in 2011. Stage 2 expanded the requirements in order to achieve more impact on your clinical processes, and the hospitals who had met the Stage 1 requirements in 2011 were in position to meet Stage 2 requirements in 2014. And the original implementation date for Stage 3 had been 2015, but as the deadline approached, an implementation date of 2016 appeared more likely. Different hospitals have progressed through the various stages of meaningful use at varying rates. Although as of 2015, the Meaningful Use program was somewhat behind schedule overall, the program has resulted in significant increase of use of electronic health records in hospitals. So even though it was behind, it truly did change, healthcare. There were more physician offices and there were more, small hospitals that, use that incentive money to kind of offset the cost of implementing those electronic health records. All right, so let's talk about something else we've talked about in health records. Let's talk about data sets. Good old UHDDS and the UACDS. That's talking about the Uniform Hospital Discharge Data Set, which is used in the inpatient world, and the Uniform Ambulatory Care Data Set, which is used in the outpatient world. So in the UHDDS, it's important for inpatient coding and reporting, as it specifies definitions and rules for selecting the principal diagnosis, other diagnosis, the principal procedure, and several other elements that are critical in DRG assignment and payment. And the UACDS is a 16-item data set that differs from the UHDDS. So the UHDDS definition and rules for principal diagnosis don't apply in the outpatient setting. So that was why there's need for an outpatient data set as well. Then we're moving on to DEEDS. Data Elements for Emergency Department System. It's the set of is a data set specific to the emergency department. It includes more than 150 data elements in the following 8 categories: patient identification data, facility and practitioner identification data, ED payment data, ED arrival and first assessment data, ED history and physical examination data, ED procedure and result data, ED medication data, ED disposition and diagnosis data. And moving down to the HIPAA designated standards, maintenance organizations. The greatest impetus toward collection of standardized data in ambulatory and all other healthcare settings has been provided by the Health Insurance Portability and Accountability Act, or HIPAA. The HIPAA Electronic Data Interchange, EDI, provisions require the adoption of standards for transactions, code sets, and identifiers. The Healthcare Financing Administration, HCFA, which is the predecessor of CMS, it delegated development and maintenance of the EDI standards to the following designated standard maintenance organizations. So we're talking about the Accredited Standards Committee X12, Dental Content Committee of the American Dental Association, Health Level 7, National Council for Prescription Drug Programs, National Uniform Billing Committee, and the National Uniform Claim Committee. All right, dropping down to that bottom section on page 55. For Medicare beneficiaries, a file called a Common Working File formerly was maintained for each beneficiary. Information from both Part A and Part B claims was maintained in these files, with Medicare administrative contractors used for coordination of benefits, for claims validation, and for tracking utilization patterns. But in 2013, CMS announced a transition from that prior Common Working File eligibility functions to the HIPAA Ability Transaction System, HETS, to work within a new 5010 transaction standard. So Medicare Part A and Part B beneficiary information is maintained within the HETS system, allowing real-time eligibility requests for coverage using a secure, closed private network to communicate with the CMS data center or via the CMS extranet. So this real-time eligibility information exchange is intended to provide hospitals with information about the beneficiary's coverage only at the time of the query. The hospital's MACs may be contacted to discuss coverage issues requiring clarity beyond the scope of the HETS. So if a patient comes into the hospital and they say they've got Medicare, well, there are certain limits on Medicare. There's certain limits on Medicaid. And so to make sure that the patient is eligible, they query these databases to ensure that the patient is eligible for services before they admit them, because, sometimes patients kind of forget things and don't realize, well, I've already used all of my lifetime Medicare days, and that has happened. But then that patient is responsible for part of that bill, and Medicare's not going to pay all of it. And so that's things that patients need to know up front. All right, moving down to the next section, we're going to quality and utilization management. Hospital accrediting agencies require that accredited hospitals implement hospital-wide performance improvement programs. For example, the Joint Commission's approach to performance improvement emphasizes designing processes, collecting data related to performance, analyzing the data collected, establishing priorities for processes to be improved, developing improvements for the priorities identified, and evaluating the extent of improvement achieved and sustained. DNV Healthcare utilizes performance improvement standards from the International Standards Organization. Organization's ISO 9001 quality management system requirements. CMS has implemented both a hospital inpatient quality reporting, the IQR initiative, and a hospital outpatient quality reporting program, the HOP QDRP to enhance public awareness of quality of care issues. The IQR requires participating hospitals to submit patient-level data on discharges involving acute myocardial infarction care, heart failure care, pneumonia care, and surgical care infection prevention. For hospitals to receive their full Medicare annual payment update for the IPPS, they must fulfill all requirements for this program. The HOP QDRP includes outpatient department measures that focus on 4 topic areas: emergency department, chest pain. Well, it's emergency department, acute myocardial infarction care, then chest pain, surgery, and then imaging efficiency. Another way in which quality affects reimbursement is the identification of your hospital-acquired infections or hospital-acquired conditions, which could be infections, through the present on admission indicator associated with additional diagnosis coded on the hospital bill for your inpatient services. Conditions that otherwise might increase reimbursement as a CC or MCC do not increase the reimbursement if they were acquired in the hospital. So what that means is when you're coding, and let's say that a patient comes in to the hospital with COPD, an acute exacerbation of COPD. If that patient is found to have pneumonia, and again, I'm just giving you examples, not whether they're 100% valid or not. A coder, I'm not. But let's just say that patient is found later to be diagnosed with pneumonia. If that patient did not have pneumonia at the time of admission, then your present on admission indicator would be N for no, and that would mean that the patient acquired pneumonia while they were in the hospital under your care. And so a lot of times what Medicare tries to do and what they've moved to is it's going to take resources for you to start treating that pneumonia. But CMS's thought is, well, you caused the pneumonia, so we're not going to pay for the care that you provided to treat the pneumonia. Now, had you cared for that patient properly and they never developed pneumonia, then you wouldn't be in any, bad situation. But anytime there's a healthcare acquired condition, they're not going to reimburse you for the care it took to get that patient back well again. So that's why those present on admission indicators are extremely important. If the patient came in with pneumonia and you're going to treat the pneumonia, then you're going to be reimbursed for that. All right, so let's move down to utilization management. Utilization management focuses on the appropriateness, efficiency, and cost effectiveness of healthcare. In the current climate of managed care and with prospective payment systems for Medicare in place, it's more important than ever for hospitals to be certain that they're rendering services efficiently. In the past, hospitals were reimbursed based on either their cost or their charges. Now, both Medicare and private payers limit the charges and costs they will pay. To operate efficiently in such an environment requires a team effort from physicians, hospital staff, and administration. In many hospitals, the staff members most directly responsible for monitoring utilization management are known as case managers. In the earlier days, case managers often focused on working as liaisons between the medical staff and the patient and patient's family to make sure that necessary arrangements were made for a timely discharge. In recent years, however, the case management team responsibilities have expanded to include working with the Managed Care Contracting Office, Decision Support Personnel, and Health Information Services, in addition to their traditional role with clinicians, patients, and patients' families. All right, so moving over to page 42, we're going to talk about risk management and potentially compensable events. So what does that mean? Many hospitals have risk management departments whose role is to protect the organization from financial loss that could occur as a result of potentially compensable events, which are occurrences that may result in litigation against the healthcare provider or that may require the healthcare provider to compensate an injured party. Almost all hospitals have occurrence or incident reporting systems that allow risk managers to track PCEs and to identify risk areas within the organization that can be targeted for improvement. Policies and procedures should be instituted to identify errors to be reported. Documentation of errors should be to the point and impartial. Some hospitals have moved from paper-based occurrence reporting to electronic systems that allow risk managers to receive, review, and analyze occurrence reports online. So we have some issues. There are some issues in risk management. These are some specific challenges. Providing high-quality documentation of all patient encounters and services is a vital component to any risk management program. If you don't have complete, legible documentation, you don't know what happened, you can't defend things. Healthcare providers must understand that only information documented in a manner that can be clearly interpreted will be used to judge whether or not appropriate care was given. Therefore, providers must ensure that all documentation is legible and complete. Hospital outpatient services present unique challenges for hospital risk managers. Financial incentives to treat patients on an outpatient basis rather than an inpatient basis should be balanced with policies that encourage inpatient admission when appropriate in a given situation. Also, the limited duration of face-to-face contact between caregivers and patients is in the outpatient setting requirement that requires extra attention to patient relations and documentation. And because telephone contact often precedes or follows an outpatient visit, documentation of these calls is necessary. What the patient tells the caregiver and what the caregiver tells the patient should both be recorded. And all phone calls should be HIPAA compliant. When the patient is not available, a message containing clinical information such as test results should not be delivered by voicemail or to a person other than the patient. Alright, so moving over to page 59, we're going to talk a little bit about EMTALA. EMTALA is the Emergency Medical Treatment and Active Labor Act. And basically, this is our anti-dumping law. So what that means is the purpose of EMTALA is to prevent the dumping of patients who may not be able to pay for emergency department services. Therefore, an appropriate screening cannot be delayed to inquire about insurance status or method of payment. So you can't have your business office staff go out to everyone in the waiting room asking if they can pay for their services, and if they can't pay, then you say, well, you need to go somewhere else. You cannot do that. If they come to an emergency department, they have to be treated whether they can pay or not, period. It's the law. So if the patient is found to have an emergency medical condition, the hospital is required to stabilize the patient before attempting to transfer them somewhere else. And in the case of a woman in active labor, stabilization generally means that delivery is completed before transfer. I'll use this example. North Mississippi Medical Center has several different community hospitals. So we're going to use IUCA as an example. They do not deliver babies. They don't. They're not equipped for it. They don't really have providers that have done it. But if a pregnant woman comes to the ER in IUCA in active labor, they will deliver that baby, and then they will transfer them to Tupelo. All right, so let's talk about the role of health information management professionals. We're at the bottom of 59. So the HIM professional can play a variety of roles in hospital-based care. They can be, as traditional as they want to be. They can work in the health information services or health information management department. Sometimes they work in compliance departments. And the skills of health information managers are vital in promoting compliance with billing and HIPAA regulations. There's a whole lot of billing stuff that I do not understand, but someone with more of a coding background, they would understand that. And so, having someone with that knowledge on the coding side and the reimbursement side, that's super important. Making sure your charge master's updated. Just all of those rules, those Federal Register rules of what you can bill for CMS and what you can't, and that 72-hour rule. There's just so much complexity there that, certain health information professionals, they live and breathe that stuff. HIM has many other roles in the performance improvement, cancer registry, trauma registry, information systems, and financial services. The specifics of each of these positions will vary from institution to institution, but the general idea of what could be expected in selective positions is provided in the following section. So we're going to talk about health information services first. So the Health Information Services Department deals with both inpatient and outpatient issues. Those in leadership positions in health information services must be familiar with accrediting and regulatory requirements that affect the patient record and must provide training for others in the department as appropriate. So knowing those Joint Commission guidelines, knowing those CMS record guidelines, that's important. Then also coding specialists typically work in health information services, although sometimes they report to patient financial services or to the chief financial officer. And in some instances, coders may specialize in coding specific types of cases, such as outpatient coding. Because outpatient coding is totally different from inpatient coding. In some areas, they are spaced out and separated down into each nitty-gritty detail. You have inpatient coders, and all they code is inpatient. You have diagnostic coders who only code like your radiology test, your lab test. Then you have coders who do your observations. And that's all they code is observations. Or you have coders that only code emergency services. So in hospitals that still deal with paper records, some hospitals may have level positions designated to handle issues arising from the challenges of filing and retrieving a large number of records that may be requested at short intervals. As more hospitals implement electronic health records, positions in health information services will deal less with storage and retrieval, but will still be vital in assuring the accuracy, completeness, and legal acceptability of the electronic record. Activities such as release of information or data collection and analysis are still within the purview of the health information manager, whether that record is paper or electronic. We have compliance officer. Most hospitals appoint full-time compliance officers who manage the compliance program. A health information manager possesses skills ideally suited for this position. In a large hospital or academic medical center, the compliance of many activities may be monitored, and a number of health information professionals may serve on the compliance staff. In many hospitals, the compliance program has developed into a distinct department. Health information managers may lead the compliance department and or work in specialized compliance areas within the department. For example, some members of the compliance staff may focus on coding and billing issues, which requires expert knowledge of documentation and coding guidelines. All right, and then switching over to page 62, we have revenue cycle. In a typical business, the revenue cycle involves all of the activities from pricing to selling and then collecting what is owed from the purchaser. In healthcare in general and in hospitals in particular, the revenue cycle is complex for many reasons, not the least of which is the involvement of third-party payers. To present an extreme oversimplification of the hospital revenue cycle, the revenue cycle begins before any services are rendered when the patient identification and insurance information are collected. Then, as the patient begins to receive services, there are charges to capture and clinical documentation to be recorded in the patient record. At the conclusion of services, information from the record must be abstracted and coded for the bill. Drop it down to the next paragraph that starts with because many of the activities in the revenue cycle involve matters in which the health information manager possesses expertise. An HIM professional can play a variety of roles. This is not making sense, sorry. I'm going to go back and reread that sentence. Because many of the activities in the revenue cycle involve matters in which the health information manager possesses expertise, an HIM professional can play a variety of roles in this arena. That sentence doesn't make sense, sorry. One obvious role in that of coding specialist, which has already been mentioned. Clinical documentation improvement programs also are important to the revenue cycle, and HIM professionals are knowledgeable about the type of documentation needed for accurate coding. Because much of the coding for an ambulatory patient's bill is generated automatically by the hospital's charge master, someone with knowledge of coding has to be involved in charge master maintenance. And then you have other roles. A health information manager can play many other roles in the hospital setting. For example, performance improvement is an area in which the skills of health information managers are well utilized. An HIM professional can serve as a performance improvement specialist, collecting, analyzing, and reporting data. In some hospitals, a health information management professional serves as a director of the performance improvement department. And health information professionals sometimes play a role in utilization management, medical staff services, and in many other areas of the hospital. So, let's talk about trends. Hospitals continue to merge with other healthcare facilities and to incorporate a wide variety of ambulatory and other services into their systems, increasing the complexity of healthcare hospital-based care. The role of the hospitalist in caring for inpatients has expanded greatly since the mid-1990s, and more growth in the number of hospitalists is expected in the future. Although the number of long-term acute care hospitals rose dramatically in 3 decades following the 1980s, the growth rate in this sector seems to have stabilized in recent years. Federal regulators and private accrediting organizations have placed a renewed focus on quality improvement initiatives within healthcare organizations. Reimbursement rates have often tied to these initiatives and reported data made available to public via the internet. Implementation of electronic health records is accelerating rapidly in light of incentives and penalties promulgated by ARA. One trend that cuts across several areas, documentation, coding, reimbursement, and revenue cycle management, is the increasing scrutiny given to coding and payment issues by auditing initiatives such as those described in Chapter 1. Health information managers will experience increasing opportunities and challenges in addressing the information needs and reimbursement required of more complex hospital and healthcare networks. All right, and so in summary, within hospital services, hospital-based systems, there's a range of services and there's many types of caregivers. You have your licensure, which is state mandated. And you have accreditation, which of course is voluntary, but being accredited by Joint Commission means that CMS is not going to come knocking on your door for a survey. They all have their documentation issues, reimbursement issues, coding and classification, data and information flow, data sets, the UHDDS for your inpatients and the UACDS for your outpatients. And we talked about quality assessment improvement, utilization management, risk management, the roles of the health information professionals, whether they are in traditional health information service roles or they're working in compliance or they're within the revenue cycle, which usually your health information department is part of the revenue cycle. They're the mid-level revenue cycle. And then a lot of performance improvement opportunities there as well. And then the trends that we've talked about. So again, read this chapter, be familiar with this chapter. There's a lot of information in this hospital section. So the more you read over this information, the better off you're going to be. Thank you very much.